right. So we're gonna, like I said, we're going to start with number 6 on the respiratory and cardiovascular system. So everything that we talked about last week with the 30,000 series was all with the respiratory. Um, and then, so number 6, we're gonna jump into directly into the craziness that is your cardiovascular system, and we're gonna look at the CPC. So with this question, we have a physician performs a 4-vessel autogenous, meaning that it's 1 vein and 3 arteries, coronary bypass on a patient who had a previous CABG 2 years ago. And they utilized the saphenous vein, the radial artery, and the left and right internal mammary arteries. So we're going to take a look at our codes from here. Okay. So let's look at this from a testing perspective instead of a coding from scratch. Because whenever we see these on the tests, these can be a little intimidating. So I want to kind of look at this one from a testing perspective. So first thing we're going to want to do is go to these codes here. We've got the 33535 is in 2 of our options. So letter A and letter D has 33535. So let's flip to those codes. Okay, so 33535. That is going to be for a coronary artery bypass graft using an arterial graft. And then it's for 3 coronary arterial grafts. So because we had 3 arterial grafts for that CABG or the coronary artery bypass graft, right? Then we know that our 33535 is going to be an option because the 33534 is for 2, and then 33533 is for a single arterial graft. Okay. So that gives us the arterial portion of our CABG. Now, this is where the tricky part comes in, is looking at the venous portion. Okay. So the venous portion of that, if we look at so we see that the 35600 is in both, correct? So we don't need to necessarily harp too much on that 35600 because we know that's a correct code. The 33510 or the 33517 is where we need to kind of look at from a vein portion. So does anybody want to come off mute and tell me what is the difference between the 33510 and the 33517? Because they're both for veins, but what's the difference between the 10 and the 17?
The 17 is an add-on code.
Okay. Yep. So the 17 is if you look at the heading for your 33517 and that whole group, you see how the heading is a combined arterial venous grafting for the CABG. And then your 33510, the heading for that is a venous grafting only, right? So if you have a CABG where they're using just the veins and they're only bypassing the veins, then you would use your 33510 through 33516. If they are using veins and arteries that they're bypassing, then you have to use your 33517 through 33523 because those code descriptions describe your venous and arterial grafting. Does that make sense? any questions, anybody confused on why we would want to use the 33517 instead of the 10? Okay. So from a testing perspective, or even like a notation perspective in your CPT book, I always have notations in there that on the venous grafting only on that page, that I have a notation that says if grafting arterial and venous, use this other set of codes instead, right? So that way it's just kind of a little bit of a visual reminder that even though my codes say that it's a vein only, right? And then your 33517 through the 33523 is going to give me my vein and artery, but it's the venous component of that vein and artery. And then you still have to code your artery separate. Okay. I know that's that's a point of confusion for a lot of people. And they're like, well, they basically say the same thing. What's the difference? Right. So again, your 33510 through 16 is if you're only grafting your veins, and then your 33517 through 33523 is if you are grafting veins and arteries, and that's for the vein component. Now, the rest of it, so we know from a testing perspective, we know what our answer is, right? Because we know that it's not A, because it's got that 33510 instead. So we know from a testing perspective, without looking at any of the other codes, we know what our answer is, right? We know our answer would be letter D. However, I do want to go ahead and at least show you the other two portions, or the other two codes that we're going to pull out from a documentation standpoint. Okay. So this patient had a previous CABG 2 years ago. So this is telling us that this is going to be a reoperation. Okay. So because it's a reoperation, if you look at your 33530, that's telling us it's the reoperation of your CABG more than 1 month after the original procedure. So we would need to code your 33530. And then can anybody guess what the other code is without looking at the code description? Can anybody guess what the other code is that we're going to code? Like I said, without looking at the code description, because we know what the code is, but what are we going to pull out of this documentation?
Harvesting?
Okay. Yep. It's going to be our harvesting. So do you know which one it is that we're going to report of all of the veins and arteries that we used? Which one are we going to report? Because there's a couple that are included, right? So there's only a single one of them that we're going to report separately. Which one is that? Do you know?
The radial artery?
Yep. So our upper extremity arteries, those can be reported separately. So our radial artery is going to be our 35600. So you even have in your guidelines, whether it be in the venous grafting, the combined venous grafting, or the arterial grafting, you have a guideline in each of those three sections that talks about the harvesting or the procurement for the saphenous vein is included. So it should not be reported separately. So we're not going to code this one separately. And then procurement of the artery for grafting is going to be included in the description of the work and should not be reported as a separate or co-surgery, except when it is an upper extremity artery. So then it goes on to say that the reporting or to report harvesting for an upper extremity, you can use either 33509 or 335,600. And then if you were harvesting an upper extremity vein, then you would use 35500. And then if we are harvesting a femoral popliteal vein, then you should report 35572. So in this scenario, the only one that we can report is going to be our radial artery. So again, an upper extremity artery or that femoral popliteal vein, those can be reported separately. Okay.
I have a
Annie?
question.
Yep.
Yep.
Nope, you're good.
On that last code with the modifier
Okay.
51, in the book, it has the icon modifier 51 exempt. I guess I don't understand that.
You know
To
what?
me,
You're
it's
totally right. I have a note
I was
here. I've
thinking
been
the
meaning.
same thing
Yep.
too.
I totally forgot that this is the same question that I had a student ask me about the other day. And I have a note that I need to send AAPC an email and have them update the question. So in the real world, you obviously don't want to report your 51, right? But from a testing perspective, if they have it on there, don't not choose it because of that, right? So in testing perspective, you would still obviously just choose that because that's the closest. Everything else matches. The code is the same. It's just your 51. But in the real world, we just would not report that 51.
okay. So if it had the answer D, like you have it right now without the modifier, and
Mhm.
say C was exactly the same with a modifier.
Well, from a
just-
testing perspective, I don't think they're going to do that to you.
Okay.
They're not going to be that tricky, right?
Okay.
If they were, then obviously you would choose your D because that's the most appropriate. But you can see that their differences in it is more than just that 51 there. They've got a bunch of other differences, right? So they've got a single artery and then they've got multiple veins. So they're just looking to make sure that you're paying attention to the arteries, and then your combined arterial and venous code, right? Those are going to be the big things that they're going to test you on. But yeah, like I said, this is one, and I totally forgot until I just looked at this because I wasn't even looking at the 35600 in the code book because I know what that code is. So, but yes, from a real world perspective, you would not put your 51 on there. So I'll make sure I get that updated and sent
Hey,
over to AAPC so that they know that that is.
Tiffany,
Yes, ma'am.
wasn't it about number 3 about bilateral? I thought it was about 3 of last week.
No, this is a different. This is from where I was meeting with one of my legacy students that I
Oh,
have the
okay.
note for that. But yes, the
Okay.
number 3 for the bilateral, that's one that I am going to talk to them about.
Yeah, we had to get that
Have
out
them
there.
update
Okay.
that. Yep.
Okay. Just
Yep.
trying to keep up. Thank
No,
you.
I know. You're welcome. Thanks for keeping me honest. Because, like I said, I have a list of ones here that for some reason, and I've been working out of these test banks for 6 months. And this just kind of goes to show you that sometimes, you guys are catching detail, as new coders, you guys are going to be a lot more, what's the word? You guys are going to be a lot more attentive to some of that detail. So thanks for keeping me honest on it because sometimes I
Not
need it.
honest, just confused at first.
No, yeah, no, and that's totally fine. I mean, but sometimes it just, like I said, you guys are so used to double checking and triple checking all of these little things, right? Because that's what your instructors kind of hone in on is make sure you're looking at this and don't do this and don't do this. But then AAPC, I've looked at these questions for so long that I'm just used to it having it on there. And I'm not sure if they just updated it from last year and the 51 was allowed last year and it's not allowed this year. I don't know if they've updated it. I haven't really done a whole lot of research on it. So it could just be that it was allowed last year and then it's not allowed this year. I don't know. We just have to look at it and see, what the differences is and just make sure that AAPC updates it. So but I mean, good catch on both of those. And for some reason, like this 30,000 series is one that a lot of people have kind of talked about how there's been a couple typos in it. So, okay. Any other questions? Okay. Number 7, we have a physician changes the old battery to a new one in a patient's dual chamber pacemaker. So basically we are upgrading it, and we're changing it from, no, sorry, this one isn't the upgrade. This one is, we're just changing the battery, okay, in that pacemaker. So any question or any thoughts on what we would look at in your alphabetic index? So let's look at this one from a scratch perspective. Any thoughts on what we would look at in the alphabetic index for this scenario?
Pacemaker?
Yep. Yep, you can look at pacemaker. And then underneath pacemaker, you have 2 options. Your first, like in your main indentations underneath pacemaker, you have a leadless and then with leads. So which one do you think we should use for this one?
Lead.
Yep, it has leads because we're doing dual chambers. Yep.
Yeah,
So
lead.
you can assume that, yep, it's with the leads. Yep. And then underneath pacemaker system with leads, which one do you think, what option do you think we'll use from here?
Replacement.
Okay.
Pulse
Yep.
generator.
Replace.
Yep.
Yeah.
Yep. Replacement and then pulse generator. Yep. Okay. So that gives us a range of codes, right? So what's our range of codes we're going to go look at?
Three 33227 to 33229.
Okay. 33227 through 33229. And then which of the 33227 through 33229 should we use?
228.
Yep. Your 33228 because it's for that dual lead. Here. So again, we are basically replacing, so we're pulling out that pulse generator and then we're inserting a new one. So it's going to be the removal and then replacement of that pacemaker pulse generator. And then again, 228 because it's a dual lead. Okay. Any questions on that one? Okay. The next one is an ICD-10 scenario, and this is one that you'll see quite often. You might even see something very similar to this on the exam. So we have a patient is diagnosed with acute systolic heart failure due to hypertension with chronic kidney disease stage 4. So there's a big guideline that we should follow with this one. Does anybody know what big guideline I'm talking about?
Is it the category 13, I-13?
Yep.
For
Yep.
the
So
hypertensive
anytime we
heart
have
and chronic kidney?
hypertension, yep, anytime we have hypertension as well as heart failure and or kidney disease, we can assume that causal relationship. Yep. Absolutely. So we can go to main term hypertension in our alphabetic index. So again, let's just kind of look at this one from an alphabetic index standpoint. So we'll go to hypertension. Underneath hypertension, you can go down to with, and then you see that there is heart failure, heart involvement, and then kidney involvement. So again, you can assume that causal relationship. You can also go to hypertension and then kidney, and then with heart disease, and it tells you see hypertension, cardio-renal, which is telling us that it's both, right? It's got cardio with heart involvement, renal with kidney involvement. Okay. Is everybody following with the hypertension? And then you're to your cardio-renal disease. So we have with heart failure, because we have acute systolic heart failure, right? And then we also have, again, that stage 4 CKD. So we should use what code for the cardiorenal systolic heart failure and stage 4 CKD? Anybody want to guess? Your
I 13.
Yep. I-13 what?
0.0.
Yep. 0.0. Yep. So just make sure that even though we think, when we think of I-13, right, we think that, you know, like dollars and cents, right? So we think of that 0.0, it's all the same. But technically I-13 is going to just be our category, and we have to have that fourth character there in order for it to be a valid code, right? So this is our hypertension. I'm just going to highlight the hypertension portion, even though it includes everything. I'm only going to I'm only going to color code the word hypertension, because then we still have to code separately our heart failure and our kidney disease, right? So if we look at I-13.0, so if we were just to look at the index, right, and not code it directly and check it back in your tabular, then your gut would kind of tell you, according to the index, it's just I-13.0, and it's gonna include everything, right? But if we go look at I-13.0 in the tabular, then the tabular gives us those use additional code instructions, right? That's telling us that we have to code the type of heart failure as well, and the stage of chronic kidney disease in addition to just the I-13.0. So again, that's another reason that you want to make sure that you verify everything in the tabular to make sure that you are using all of your codes. So from there, if you want to look it up in the index for the acute systolic failure, the acute systolic heart failure, you would look up main term failure. However, from your use additional code to identify the type of heart failure, then it does give you that category I-50. Okay. So we can flip directly to I-50. And then looking through the I-50 category, what code is going to be applicable to acute systolic heart failure?
The I-50.21.
Yep. Yep. Our I-50.21. Perfect. And then we need to figure out our code for this stage of chronic kidney disease. So if we had made note when we were in the I-13.0, then your kidney disease is going to be your N18 category. So we can flip directly back to N18. If not, then you can always go back to your alphabetic index and look up disease, kidney, and then it's going to send you back to the N18 category. And then what code are we going to use for stage 4 chronic kidney disease? Yep. N18.4. So N18.4 for our stage 4 of chronic kidney disease. So that's going to give us letter A. So just make sure you know that we know that we have that causal relationship, right? Just make sure that you know that there's a combo code for hypertension with both heart failure and kidney disease. And you wouldn't code hypertension with heart failure and then hypertension with kidney disease. You're going to use your combo code that's going to be the I-13.0, which is for both heart failure and hypertension. Okay. Any questions on that one? Okay, perfect. So now we're going to flip back to CPT. Okay. On number 9, we have a PIC with a port is placed under fluoroscopic guidance for a 45-year-old patient for chemotherapy infusion by a physician, and the procedure was performed within a hospital. So let's report the codes for the physician. So for this one in our alphabetic index, let's look at this one from a scratch perspective. What do you think we'll look at in the alphabetic index? Anybody have a guess? Yep, PIC line, the PICC line. Okay, so you can look up PIC line and then underneath insertion, which option are we going to choose? You've got 2 options.
With a port.
Yep, with a port. Yep. So what code does that send us to? Or codes does that send us to? 3, 6, 5, 70, and 71, right? Whenever you get there, what's the difference between the 3, 6, 5, 70 and then the 3, 6, 5, 71?
Age.
Yep, it's our age. So again, here, this one gives us our age is 45 years old. So what code is that going to give us? Three, 6, 5, 71. Yep. So we're going to use 3, 6, 5, 71. Okay, so the big question is, should we report that fluoroscopic guidance separately? Or should we just report the 3, 6, 5, 71? What do you guys think?
I think we report the 77001.
Okay. Does anybody agree? Anybody disagree? I want to hear and not that I don't believe you. I just want to see if anybody,
Agree.
okay,
I
you
agree.
agree. Okay, yep. Yep, so we can report the fluoroscopic guidance separately. So we know that it's the 77001, right, from a testing perspective, because that's the only one that's there. However, if you don't have the code, you would look up fluoroscopy in your alphabetic index. And then underneath fluoroscopy, you will look at venous or guidance and then venous access device. And then that's going to give you two codes. It's going to give you 36598 or 77001. And then you'll choose your 77001. Okay. Any questions on that one? So the big difference is just, again, from a testing perspective, they're just going to test you to see if you think that your fluoroscopic guidance is going to be able to be reported separately. Okay. Okay. And then our last one, we're actually going through the cardio ones a little bit quicker than what I was expecting. But our last one, number 10, is for a maze procedure that is performed on a patient with AFib. The physician isolates and ablates the electric paths of the pulmonary veins in the left atrium, the right atrium, as well as the atrioventricular annulus while on cardiopulmonary bypass. So from let's do this one from a testing perspective, right? So none of the options have two codes and they're all different codes, right? So how would one of you approach this one?
What codes are closest together?
Yep. Yep. So you've got three codes that are the closest. You've got 33254, 33255, and then 33256. So yep, if you don't have two options that have the same code, then absolutely go with the ones that are the closest so that you don't have to flip as much. So 332 54 55 and 56. So what's the difference between your 54 55 and 56 once you guys get to those codes? Does anybody see a difference between them?
With or without bypass?
Okay. So that's the difference between the 55 and the 56. So your 54 is for a limited, right? So it's a modified maze procedure and it says limited. And then your 55 and 56 is an extensive, and then it just says maze procedure, right? So we just have our maze procedure. And then what other detail in this scenario do we need to pick our code?
The bypass.
Yep. So they were on the cardiopulmonary bypass. So which code is that going to give us?
33256.
Yep. All right, 33256.
Yes, number C.
Say that again for me, Xenia.
Yeah, number C. I was just
Okay, yeah. Yep. All right, 33256, because again, it's a regular maze procedure, not a modified maze.
modified. Okay, right.
Yep. And then it was with your cardiopulmonary
Yeah.
bypass. Yep, which is going to give you your 56. Perfect.
Awesome.
Okay, what's a maze procedure again?
Where they just go in and ablate that tissue, and then they have to reconstruct. So essentially, they're telling us what they're doing, right? Because they're ablating the electric paths, right? And then they're reconstructing that path after they've kind of destroyed whatever's there that's causing that AFib. So they've isolated the area where that AFib is happening. They're going in and ablating that tissue, which is where your AFib is occurring. And then after they do that, then they are reconstructing that portion of the atria and basically like making it whole again, I guess is the best way to phrase it. And then
Thank
so basically so if they were to say that they've done the ablation and the reconstruction but they didn't use the term maze, then you can assume that it's the 5556, right? Or if they just tell you that they did a maze procedure and then it was just in the atriums, right? Then that would still be enough documentation because you have that, for example, maze procedure in the parentheses. So since they give you that acronym for the maze, then it is enough support to be able to use it. Okay. Any other questions that you guys can think of, whether it be on either any of these 5 that we went over or on ones from last week that as you guys were going through and working on them, or just in general over respiratory and cardio that you guys can think of, since we've got about 15 minutes to chat.
On number 8, Tiffany,
Mhm.
I had trouble looking up I13.0 in my
Okay.
alphabet index. Can you
In the
walk me through
alphabetic.
that one?
Yep.
Yes, ma'am.
Absolutely. So you would want to go to hypertension.
Okay.
Okay. So your main term is hypertension. Which ICD-10 book do you have?
I've got Ultima.
Okay. I don't have, that's the one that I don't have. Okay. So hopefully you don't need help on figuring out what
I'm sorry,
page or
Optum.
in
I'm sorry, Optum.
Optum. Okay. Yeah.
I don't know why I
Yeah.
say Optum.
No, you're fine. You're fine. I've got a coworker that calls them Optimum, so it's fine. So underneath hypertension, because we have both heart failure and chronic kidney disease, then we're going to go underneath the cardiorenal disease option.
Okay, I see it. I
Okay.
got it.
And then under there. So now if you can't remember that it's cardiorenal that you need to go to, right? You can either go to hypertension and then cardiovascular, and then you've got a renal disease as well under it, and it tells you to see your hypertension cardiorenal. Or
Yeah, I
you
saw
can
that
go
and I didn't.
yeah, I was gonna say, or you
I
can
didn't
go
pick
to
up on
heart
it.
with kidney disease or kidney failure, or yeah, you do with kidney disease, or you can go to kidney with your heart disease, and it all maps you back to that cardiorenal entry.
Okay.
Yep. So your
All right,
cardiorenal is going to give you both heart and kidney involvement, whereas your I-11, I think is what it is. Yeah, your I-11 is heart involvement only, and then I-12 is kidney involvement only.
Okay. All right, thank you.
You're very welcome, love. Any other questions? Like I said, even if it's not on one of these that we talked about, if you have something that, just kind of a topic that you want to discuss, but something I can answer today, I absolutely will. If it's something that I need to research, then I can get back to you on. But anything else that you guys want to chat about since we went through these questions fairly quickly?
So I do have a question with regards to something that I saw posted by the AAPC.
Okay.
I saw them post a short video on YouTube, and it was a lady saying how the test was set up more from the standpoint of being able to know how to test well quickly
Yeah.
versus coding as much.
Mm-hmm.
Would you say it's more about your test taking skills that come into play more so with the passing the exam than the actual knowledge itself?
Yeah. Yeah. So that's why, like, on the ones where, I was saying, like, let's code it from scratch versus let's look at it from a test taking standpoint, right? So, like, this one here, number 6, we really only had to look up 2 codes to get our answer, right? So we didn't even have to look up technically the radial artery procurement or the previous cabbage 2 years ago. We just had to figure out of the veins and the arteries, which codes are we going to need? So yes, from a test taking standpoint, from a certification standpoint, it absolutely is all about your process of elimination and how to find the correct answer the fastest, right? However, we all know that test taking coding is totally different than real world coding, which is why I try to like get a little bit of both, a little bit of both perspectives, because there are some people who have already passed and they're just doing this just kind of refresh as well. And then there's a lot of people that are taking it, or I guess joining and listening in to kind of get these test taking skills. So that's why I do both, both approaches. But also, and this is one of those things too that I think I went over this last week, but I want to touch on it again. So this week and moving forward, or I guess last week and moving forward, you will have not only the multiple choice. So if you are, listening and doing these questions from a real world standpoint, then I do have like coding from scratch. It's the exact same questions that are up here at the top, but you can come down here and after you've gotten confident with your multiple choice, you can come down here and test yourself from a coding from scratch standpoint. And like I said, it's all the same questions, but if there's multiple CPTs, and I do at least give you, the blank so that you can kind of like test yourself that way. And then you have your answers down here at the bottom. So regardless of how you guys are, taking the I keep saying course, but this isn't the course technically. As we go through, like within the study group, whether you're doing it from a test taking prep or you're doing it because you're trying to relearn kind of how to do it from scratch, I give you both of those options that you can do that from. Any other questions that you guys can think of?
I have a general question
Yeah.
about the CPT book
The
and
CPT book? Okay.
yeah, the path and labs.
Mm-hmm.
That is huge, and
It's
they
huge.
have
Yeah.
renumbered, resequenced it, and oh my
Yes.
gosh, trying to
Yeah.
fit through to find the right code and where it's at. I've been
Yeah.
just going through and saying and just putting a note, see page,
Yes,
685.
absolutely.
Okay.
Absolutely. And I
Is
do
that
that through all of my sections just in general. And I tell my students to do that throughout the whole book, just in general, but especially your path and lab section, because like you said, there are sometimes that like if you already do all of the pre-work of finding your codes, if you're trying to find it during the exam, you know exactly where to go to. But yeah, I agree. Path and lab is kind of a hot mess when you're trying to find those resequence codes. There's even times that I'm flipping through it and I'm like, if I do not find this code in the next 5 seconds, I'm going to take this book and throw it out the window.
okay? Glad it's not just me
Yes,
then.
it is not just you, I promise. And it's not just me either. It's everybody. I've heard that from a lot of people. And that's just kind of my number one recommendation is go through and all of your renumbered or your out of numerical sequence codes, go through and find them prior to the exam and write your corresponding page number. So that way, if you're like searching during the exam, you're not wasting time flipping through the pages and you know exactly what page to go to.
Perfect. Thank you.
Yep, you're welcome. And like I said, that's not, I mean, if you have time, definitely do it with your other sections as well. But yeah, absolutely do it with your path and lab. Good idea. Good thing to bring that up. I'm glad you brought that up. Any other thoughts? Okay.
Are we back to Wednesdays this coming week?
Yes. Starting next week, we will go back to Wednesdays. Yep, absolutely. So everything will start again Wednesdays at 7 p.m. Yep. So thanks again for everybody being flexible for this week. Like I said, I would rather have moved it onto a different night than just totally skipping it in general. And then as you know, as always, we'll get the recording up. So even if you want to go back to it later, you can. And then for those that weren't able to make it, because I know it was a pretty small group tonight, we'll get that recording up for everybody. As soon as it processes tonight, I'll get it up in the morning. All right. Anything else you guys want to chat about?
When you said 7 p.m., did you,
Mhm.
is that Eastern Standard Time?
Yes, it is 7 p.m.
Okay.
Eastern. Yep.
Okay, thank
Yep.
you.
You're welcome. Thanks for that clarification.
I'm just trying to figure it out.
I know. I try to keep myself like humble and try to keep myself organized. And I've been trying to make sure that I say Eastern, but I didn't that time. But yes, it will be 7 p.m. Eastern. So 6 p.m. Central, 5 p.m. Mountain, and then 4 p.m. Pacific. Starting next week.
Do you know what you'll be covering in the next group? Can we go ahead
It
and
will be the
start working on it?
40,000 codes, so it will be digestive. So I will get
Okay.
those questions posted by Sunday.
Okay.
Okay.
And then just look for them on Google Drive, right?
Yep, and they will show up on Google Drive. Yep, absolutely.
Okay. All right.
Yes,
I know what
ma'am.
to do. All right. I'll go get them.
All righty. Like I said, they'll be
Thank
out there,
you.
like I said, by probably mid-afternoon on Sunday. So I will get them out there for sure. All
Thank you,
right,
Tiffany.
ladies. You are very welcome. If you need anything at all before next Wednesday, don't hesitate to reach out, whether it be, private message, or if you are on Discord and you should, shoot it in the chat or in a private message on Discord, whatever. Just let me know. And then as soon as I get to it, then I will get an answer to you. You all
Well,
have a
great
good,
weekend.
you too.
Thank
Have a great
you.
weekend, and then I'll chat with you soon.
Bye-bye.
Thanks. Bye.